Hello, everybody. I'm Ron Waksman, and my next guest is Dr. Marco Zimarino from Chieti, Italy. Welcome, Marco.
Thank you very much for inviting me, Ron. It's
And
a true pleasure.
we'd love to have you. I know Marco for many, many years when he was visiting us here in Washington, and he did his own career for himself over the past decade plus. And also very prolific writer, investigator. He is also editor of a new book that should be coming soon on aortic valve. So I thought that we're just going to chat a little bit and we'll hear a little bit. I want you to know who is Marco Zimarino. So if I have to ask you, tell me who is Marco Zimarino or or Professor Marco Zimarino, how would you characterize yourself?
I am a cardiologist that spend most of my time being interventional, but trying always to take care of the clinical strategy to optimize, aside from the technicalities, the procedure in order to reduce complication for our patients and to increase long-term outcome. And this means by optimizing the procedure itself, but also chasing, almost chasing the correct strategy for therapeutical option and in order to obtain the best follow-up from our patients, both in coronary and in structural cases.
And you've been working in Italy all the years, and Italy is one of the largest high volume with respect to interventional cardiology. But every time that I go to Italy, which I love, I always notice there's a lot of competition. You have a lot of professors, a lot of so, and it's still not a big country like here in the US. So how do you navigate? I mean, how do you survive in an environment of such a competition?
Being much more aged than before, than when I came to learn my first uh, things in Washington. It's nice because at the beginning you feel the competition, then you understand that the competition is a true meaning of improving yourself and chattering with your friend, with your colleagues, competitors that now that after become your friends. You always share something. You understand your mistakes. You overcome your mistakes, and you try to do your best, always in a sane competition. And this is a message that I learned from you, because in US I always invite the final of the finals, the seventh game of the basketball NBA World Championship, where even if you shoot your last or you miss your last shot, you go, okay, let's see next year. That's been a nice game. And that's it. We try to do our best. We try sharing with others our experience, trying to understand it always through that. Because when you put yourself in doubt, then that's when you improve.
Yeah, you just mentioned sports, so my condolences. I mean, on the loss of Paolo Rossi. I remember as a
Sure.
kid, I was watching him. Is for those who doesn't know who's Paolo Rossi, he was one of the most brilliant soccer player, I think, in Italy, and we just lost him this week. That
And his history was really the history of a normal player who became a real champion with he was a very humble guy that was the smallest of the team going against the big Brazil in a world championship that the Brazil had to win, and he overcome the result, and it was the and then Rossi is a surname that's very common in Italy, because you're often in Italy. So it's a quiet man's story, a normal man's story, without excesses that we see, unfortunately, often in sports. And it was really um, an icon for young players and for everybody who is approaching soccer and other sports.
Excellent. Okay, so let's go back to science. I mean, you're a scientist. You just published a very interesting paper in Circ Intervention. Why don't you tell us about the study, what that was about transfusion, I think, post TAVR. It's a very interesting topic because we often have to do that. So tell us a little bit about the study and the findings.
Yes. The study comes from two scenarios. The first gave me the occasion to thinking about transfusion was the TRIX study. It was performed in cardiac surgery. They randomized more than 5,000 people after cardiac surgery, choosing between a liberal transfusion strategy, meaning a transfusion when the nadir hemoglobin was below 9.5, versus a restrictive strategy, transfusing patients when nadir or when hemoglobin dropped below 7.5. Transfusion is a noble blood that support for the patient, and in patients who undergo extracorporeal circulation, this is a major issue. The results of the study was published in 2017 in two shots of New England Journal of Medicine, 30-day outcome and 6 months outcome, was the equal outcome, a similar outcome in both arms, and and they studied that MI and acute kidney injury requiring dialysis. This is one background. The other background is our setting. In TAVR, we cannot modify slowly the volume of the patient when we change in 20 seconds the loading of the patient. The main issue of the patient with aortic stenosis is the diastolic impairment. So really in the first phases of the TAVR implantation, when you modify all suddenly the valve, you annihilate the pressure gradient between the left ventricle and the aorta, so you unload abruptly the left ventricle, and you can have a phenomenon that is called the suicide left ventricle, a ventricle that has no chance of dilating for obtaining an adequate diastole. So without the diastolic period, then you can have a pressure drop and the patient can go in a severe hypotension. So the patient has to be refilled. Refilled with what? If you refilled with fluid, direct fluid repletion, you can have an hemodilution in a patient in which you have large bore femoral abscesses and in which you cannot realize if the patient is bleeding during your valve implantation or not. On the other side, you can refill the patient with a noble compound, that's red blood cell transfusion. And in this case, people is always more confident of improving oxygen transportation, of improving the performance of the patient, increasing the fluid repletion of the patient. We, starting from the TRIX trial, we wanted to check if this transfusion strategy would be beneficial for the patient or would be harmful. And this was the aim of our study.
The patient population obviously undergone TAVR, but we have patients that coming with anemia because they are sick patients, obviously, and they have maybe chronic kidney disease. And I'm talking real anemia, like hematocrit around the 20 and hemoglobin around 6, 7. And there are patients that actually do bleed during the procedure, unfortunately. So these are the two times when I see patients getting transfusion. What was the study population? Which one in your study cohort received the transfusion?
Our study population was of about, it was a multi-center registry from 7 centers, 6 in Italy and 1 in Spain. We withdrew all the transapical cases and all the surgical accesses. So we had a population of about 2,500 patients, among which the 16% of patients received at least one unit of red blood cell. And the mean units were around 2, meaning most of these 16% of patients received 2 units of blood cell. Um, Obviously, the transfusion itself may be a marker of the risk. So most of the patients who were transfused, reasons for transfusion were listed in our study and were obviously major bleeding, major vascular complication, low baseline hemoglobin, advanced NIH A class, female sex, patients who previously received double antiplatelet treatment. In order to overcome differences that were in the overall population, we performed a propensity score matching in which all the baseline variables were at equipoise, were annihilated in order to check the true meaning of the transfusion, if transfusion can be not only a marker but also a mediator of adverse outcome.
So the control group was the patients who did not receive transfusion.
Yes. In the overall population, the control group was the 84% of the population. In the propensity matching, it was a one-to-one propensity match. We identified 421 pairs of patients who received or not received transfusion.
And what did you find?
The primary outcome was the mortality. The 30-day mortality had an hazard ratio of twice the control group when receiving transfusion. So transfusion was independently also related to mortality and also with the Cox proportional analysis, we identified transfusion being an independent from major bleeding and a major vascular complication in terms of adverse mortality.
Yeah.
But not only mortality, because transfusion was also related to a 4-time increase occurrence of acute kidney injury. And I can tell you, we already checked the data in the long term. This translate into a further of the hazard ratio of mortality in at 2 years.
So it is actually known that overall transfusion is bad. And we learned it also in PCI. I think similar works were done. And the idea was that if you can change the threshold, have a very higher threshold to start transfusion, you're doing better with the patient. I think that was a known factor for PCI literature. We also looked at it here. And we tried to avoid it under the same parameters or criteria. But in this study that you have, this is relatively a short outcome. You're not talking about like many years of follow-up. And my question here uh, is it really possible to propensity match this population? Because there are very, I mean, when you have a catastrophe in the lab, that's a catastrophe. I mean, you cannot propensity match the catastrophe when you give transfusion and you don't give transfusion. So you're basically already very biased by the group selection. So I know the magic word we use propensity, but so your thoughts about that comment?
So, you are a doctor, and you know that it occurs all the time. We One instrument is propensity matching. That's a post-hoc randomization, but it's a post-hoc randomization. Also, we try to settle the cutoff using the tricks, meaning under 7.5, between 7.5 and 9.5, and over 9.5 hemoglobin nadir. And we identify that transfusion increase the mortality mostly in patients at the two edges of the curves, meaning either patients who are under 7.5 or patients who are over 9.5. But sometimes that nadir is not the true nadir because you have the perception that you transfuse the patient without checking, or transfuse the patient with your feeling. In the other direction, you transfuse the patient blindly because you have an hemodilution for the reasons we spoke before. So it's always, it's true, it's a study full of bias.
But do you feel that the patient died more because of the extra? Sorry. Do you feel that the patient? You feel that the patient? Yeah. Yeah, the connection is not good now, so I don't know. I mean, we can wait a second, and hopefully this connection will be better. Okay, let's try again. Do you hear me well now?
Yeah.
Okay, let's try again. My question is, do you think that the patient died more because of the transfusion per se, or because of their state of the disease before or the complication? What was, you think, drove the mortality?
I agree with you. The problems, and we saw also from the recent reported controversy in the antithrombotic trials, Popoartavi and Galileo, that these population have such a high risk profile that's always difficult to randomize these patients. At the end, the only message that you can derive from the trial is a primum non nocere, meaning try to have the lowest profile possible in this kind of patients. Because whenever you go more, you know that our first enemy is that much better is worse than better. So we can only derive a fair message from our study, meaning that, try to reserve transfusion only to patients which you really feel that deserve it, not to clean the hemoglobin state, not to have a better oxygen transportation, not to have a better risk profile, because in those cases you are perhaps more harming the patient than obtaining a good result, because you are absolutely correct. When there is a catastrophe, you have to transfuse the patient. You cannot wait and see.
Marco, thank you for your contribution on this paper. I take the message. We need to minimize, if we can, transfusion also in TAVR patients. That's the message I take. I mean, you concur with it. Okay, few words before we end. Do you want to talk a little bit about the book, when that's going to come out, and what we're going to find in this TAVR book?
Our book has been a fantastic trip, meaning we all worked hardly on this. It's a pleasure because we share, me, you, Corrado Tamburino, Ignacio Amat Santos, joining a lot of very nice contributions from very, very distinguished colleagues that gave us their support. And by reading it, I really learned a lot in trying to identify, prevent, and treat all the single complication that we have during our TAVR procedures.
Yeah, and the book is going to come in the next few months. Do we have any timeline from, I mean, it's going to be definitely
I think
2021.
that the book should sort out in the first quarter of the next year. I think it will sort out between February and
Yeah, and I
March.
can assure you it's going to be a bestseller. And the first edition will go very quickly. So I advise you to start to work on the second edition.
Okay, thank you so much, Ron.
Good. And Marco, it's always nice to see you. Unfortunately, this time only virtually, but at least we do have you as a guest in our show. My next guest is, and I'm looking forward to see you in person. I see you still have the mask. Italy is still under siege with the corona and the COVID, but we are
Yeah.
starting the vaccine here next week. We are hoping to get over this as quickly as possible, so as for Italy. So in the meantime, stay safe, my friend, and we'll see you hopefully shortly face to face.